works. Cancel prize coming, right? Lane's not. I might get started. Long one. Yeah, we're gonna together the talks for this year. We just went off of like the ASCS recommendations and then realized reverse shoulder arthroplasty is kind of a big topic for 45 minutes. I'm probably going to get started, but basically how I wanted to do this, because again, there's like a million things to talk about, sort of take a page out of Dr. Chalmers' book, how he did things last week, and kind of talk about how we got to where we are with reverse, and a little bit on indications and complications, but really the whole picture that I'm going for here is why at least I do what I do in reverse as far as design, philosophy, implant, orientation, that sort of thing. And hopefully from like a resident fellow standpoint, give you guys a little bit of a feel for some of the decisions that are being made when we're deciding what type of implant to do. Maybe I overthink things, but that's sort of my what I wanted to go with here. There's about a million other side topics that we could talk about here, so we'll try to kind of keep it focused on that. So history, a couple things that I wanted to go through here. So first of all, you know, when you talk about shoulder surgery, it's probably good to know where things came from. On the left is Emil Pion. I don't know how to say that exactly, but he's widely credited with doing the first the first shoulder replacement was essentially the reverse shoulder in 1893. The guy on the right is Themistocles Gluck. He probably actually performed the first shoulder replacement in the 1880s, made out of ivory and some other interesting things, but he had never really published as far as shoulder replacements go. This is what the very first one looked like. This is in some museum somewhere, I think. It was a combination of platinum and rubber. So the ball was like a hardened rubber, and it had two different rings on it, which allowed for motion. The first case was actually the first like several cases of shoulder replacements were in people that had tuberculosis and huge destructive joints. And so they did this, which, you know, in retrospect, putting a arthroplasty in an infected joint, probably not a great idea. But the first guy was a, the first documented one, 1893, was a 37-year-old baker that had tuberculosis, and he refused an amputation. So some dentist in Paris put this together, and Dr. Pan put this in his shoulder. Guy was admitted for like 6 weeks or something. Went home, actually did really well per report for about a year to 1 to 2 years. And then he came back with recurrent infection. They had to remove it all. Which is kind of a bummer. But so what I want to talk about is how do we get from this to where we are now? And there were several steps along the way, I think, that were kind of these leaps that I think are important to know when you're considering what we do in reverse shoulder arthroplasty and a lot of the discussions that we still have surrounding design philosophy. So the general concept of a reverse, at least how I like to think about it, maybe it's a little bit oversimplified, but essentially the reason that this came about is if you do like a standard shoulder replacement in somebody with no rotator cuff, the ball does not really stay stable on the socket, right? And it leads to failure and poor motion and that sort of thing. So we need to find a way to essentially constrain and create a stable pivot point for the shoulder to move around. And the best way to do that and constrain the shoulder without really sacrificing motion is to do a reverse shoulder replacement. And this is one of Frankel's little video things, but basically on the left, it shows that if you don't have a rotator cuff to help keep the ball stable on the socket. When the deltoid fires, it's just going to ride superiorly, and this is essentially what anterior superior escape and the origins of cuff tear arthropathy are. Whereas on the left, if it works again, if you're able to constrain the on the right. No, it's not going to work. But on the right, if you're able to constrain it around a stable pivot point, then when you fire your deltoid, the arm is going to be forced around that pivot point so you can retain your motion in the shoulder. So this concept, these are just some pictures of different arthroplasties through the 70s, 80s, that sort of thing. And you can see a lot of these are reverse shoulder concepts. And the idea was to basically address rotator cuff tear arthropathy / massive cuff tears with pseudoparalysis, that sort of thing. You can see a lot of these look like people just forced a hip replacement into the shoulder or the scapula. And, not surprising, a lot, this is more recent, but a lot of these ended up with failure. And this was one of the main failure mechanisms, is that the base plate could not sustain the forces that it saw on the bone, and it led to base plate failure. Also very poor motion in these patients. But these were two of the main reasons for failure through the, I'm probably overgeneralizing, good 70s, 80s, 90s almost, which led to a lot of people completely abandoning this, at least around here. And then in 1985, Paul Grammont sort of changed the design philosophy for reverses. And he had a couple of ideas. So the one idea is that it would be a larger glenosphere than normal, and it would be more medialized center of rotation. The way that he did that is, instead of having an entire sphere sitting off of the glenoid, it was basically half of a sphere. The other thing that he did is he had a non-anatomic neck shaft angle, so 155-degree neck shaft angle, which basically would distalize the humerus. So this did a couple of things. So number one, by medializing the center of rotation, this is what, from a resident standpoint, everybody hears reverse and like, oh, medialized center of rotation. The reason for the medialized center of rotation is twofold, but really this helped decrease a lot of the torque that the base plate was seeing at that base plate bone junction. So it decreased the amount of failures at the base plate bone junction. Number two, by medializing the center of rotation, it allowed your deltoid force vector to have basically generate more torque, right? So it allowed people to elevate their arm better than previous designs. As far as the 155-degree neck shaft angle, this essentially distalizes the humerus, which increases deltoid tension, which also helps to improve forward elevation and abduction. This also helped with stability. So this was 1985, and then really through DePuy, several iterations of this kind of through 80s, 90s, 2000s, up to today. But this is sort of what a Grammont style implant looks like these days. And actually, sorry, yeah, this is what a Grammont style implant looks like these days. But probably the biggest issue or the biggest complication that was seen with this was scapular notching. So if you look at historically with these Grammont style implants, when you are medializing the center of rotation and basically medializing the humerus as well, the inferior femoral neck or the polyethylene liner is going to hit the scapula, cause scapular notching. Historically, with these types of implants, it was like almost 100% of patients would get scapular notching. There were some changes in design philosophy to help avoid that, and it's still seen today. There's probably a little bit of debate how much it matters, but uniformly, if it gets bad enough, you can have base plate loosening, and generally it's associated with decreased range of motion and worse functional scores. So then Dr. Frankel, and if you haven't, I'm sure you guys have, I don't know, Mike, if you've heard his talk about sort of the evolution of the reverse, it's good talk. But he tried to fix this by creating this implant. And he did this, this is about 2002. I think FDA approval for this was in like 2005 or something in the US. But he did this by lateralizing the center of rotation. So, the lateralized glenoid that we're going to talk about is really just in comparison to the Grammont style glenoid. It's not actually lateralized compared to the humeral center of rotation, but he lateralized the glenoid, and then he also changed the neck shaft angle to 135 degrees, which is really more of an anatomic position for the rotator cuff, as opposed to 155 degrees. And the idea is that this would address the issues with scapular notching, and it helps improve kind of the deltoid wrap around the humerus, as I said, putting it in a little bit more anatomic position, and ultimately helps with a little bit more rotational motion. So that more or less kind of brings us to like really the two, like, I don't know, main design philosophies today. And these types of implants are still 100% available, and you can construct them with maybe not most systems, but a lot of systems. On the left is the, I think that's the Delta Extend, which is essentially a Grammont style implant, still comes in 155 degrees and a 0 millimeter offset lateralization from the glenoid if you want to do that. And then on the right is the more modern version of Frankel's prosthesis, which is this is technically the Altivate, Enovis Altivate, but it's 135-degree angle. And that sphere there, Mike, you probably know this well, but that's a 32 neutral sphere, which is kind of how Frankel initially designed his prosthesis around. That's 10 millimeters lateralized from the glenoid surface, which is quite a lot. So again, the next couple slides here are really focusing on indications, complications as an overview, but really how these shape what I do when I'm doing a reverse shoulder arthroplasty. And I'll kind of go through these. And then I've got a little algorithm here that I'd love to see what Dr. Chalmers thinks, because he does things a little bit differently than me. So indications, as far as like OIT questions and stuff go, I don't even know what OIT question would be. They tend to be about 5 years behind, but these are some of the big ones that you see. So cuff tear arthropathy, relatively obvious. Large irreparable cuff tears without arthritis, glenohumeral arthritis with bad bone. We'll talk a little bit about that. Proximal humerus fractures in the elderly, failed anatomics, failed reverses, whatever. But then if you go through it, there's like a million different ways that you can do this. And, it's kind of, some of the discussion here is, are we putting reverses in too many people as the indications continue to expand? And we don't really know, because they seem to do reasonably well. But anyway, so cuff tear arthropathy, this is really the quintessential indication for reverse. This is why the reverse shoulder arthroplasty was created. Probably the biggest thing to keep in mind is if you see an x-ray like that, obviously you got to treat the patient. There are a ton of people that have an x-ray that looks like that actually have minimal pain, reasonably good function. They've just compensated well. But if you see an x-ray like that, the only surgical treatment option for them should be reverse shoulder arthroplasty. Massive cuff tears without arthritis, and we'll talk a little bit about this in the next couple slides, but this is, I don't know what your thoughts are on this, Peter, but essentially for me, this is a group of patients that have dysfunction, that don't have arthritis, but they have a massive cuff tear that if we were to fix it, I don't think it would heal, or I don't think they would do well. This is elderly patients. Really, the results from this, for me, have not been as good as doing reverses for arthritis or even really cuff tear arthropathy. Some of the risks associated with seem to be a little higher, especially instability. So for me, this type of patient, they have to fail non-op treatment first. So that means injection, physical therapy, that sort of thing. Pseudoparalysis, true pseudoparalysis where they can't forward elevate their arm. Jerry Williams would tell me this, and I kind of agree. I don't think that can really be addressed any other way than with a reverse shoulder arthroplasty, unless it's like a very acute cuff tear that you could fix. And then severe atrophy, that sort of thing. But so osteoarthritis. want to talk a little bit about this. So this is probably, if you look at the number of reverses that were being done, 15 years ago versus today. So 15 years ago, the majority were cuff tear arthropathy type patients. And if you look at some registry stuff, I think it was like 60 to 70% of reverses were done for cuff tear arthropathy. And if you look at more registry data from today, the most common indication for reverse is osteoarthritis with intact cuff. And that's somewhere around 50% of reverses that are being done, based on a lot of the studies that you look at are being done for arthritis. The reason I put this slide up here is doing a reverse for OA, it's not the same as doing a reverse for cuff tear arthropathy. And, this is something that, I don't know, maybe through fellowship, I took for granted a little bit, but these are very different patients on this board, and they're going to do very different. Their complication profile is very different. Their outcomes are going to be very different. Maybe not very different, but it's important to know that going in. So every reverse that you do is not necessarily the same. This is from Mike's former home, with a much more research-oriented resident on there with Rick. I'm just kidding. But so a lot of this, I mean, you can kind of look wherever you want to look for this, but this was a JAOS paper from these guys a couple years ago, basically just retrospective looking at people that had a reverse shoulder arthroplasty and comparing people that had primary bony humeral arthritis with intact cuff compared to cuff tear arthropathy. And you can kind of see here on that table on the right, the ASES score, so functional scores, pain scores, forward elevation, external rotation, all were significantly better in the OA group compared to the cuff tear arthropathy group. If you look at the numbers here, you can argue minimal clinical MCID stuff, but these are pretty significant. I mean, it's a 10-point difference, over a 10-point difference in ASES score, over 10 degrees in external rotation and forward elevation. So very much significant. And this has been shown, across a number of different studies. Frankel looked at his own patients, 700 patients that had a primary RSA, and essentially saw the same thing. His results weren't as polarizing, I'd say. The pain scores were relatively similar, but the ASES score was about 8 to 10 points better in the OA group compared to the cuff tear arthropathy group. He also had lumped in massive cuff tears. And then kind of interestingly, subcategorizing that, the patients with massive cuff tear with no arthritis did the worst, or at least had their functional scores were somewhat similar, but had significantly lower satisfaction rate. So something to keep in mind. So, really when you see these two things come in, Hansel, if you're doing these things, you got to understand, like when you're talking to somebody, if they don't have a rotator cuff versus if they have arthritis, from a functional standpoint, outcome standpoint, these are not the same thing. People can still do very well with cuff tear arthropathy, but anyways, this is really, for me, this is very generalized, but in general, if I see somebody with osteoarthritis that comes into my office and their cuff is intact, when am I considering doing a reverse? So if I'm looking based on, just specific criteria, largely if they're retroverted more than 25 degrees, I'll lean towards doing a reverse. Significant posterior humeral head subluxation, I'd say 80%. There's certainly people that I'll do an anatomic on that are less than 80. But I worry that if we put an anatomic in there, it's going to get rocked loose. And then bone loss, 7 millimeters. This is a Williams thing, but he would basically make a line where he thought the paleoglenoid would be, and then measure the amount of bone loss here. And anyways, these are all measures of amount of bone loss. But really, probably, I don't know, at least 50% of my decision process comes from patient factors, what their range of motion is, age, if they've got osteoporosis, inflammatory arthritis, that sort of thing, cysts in the glenoid. These are things that I really probably factor in more so than what their actual anatomy looked like. So complications, The two complications I'm really going to talk about here are the two main ones that are theoretically modifiable. There are some other complications, but the first one's dislocation. Historically, this was the most common complication. I don't know if that's actually the case anymore. I think if you look at some of the numbers from more recent studies, it seems like acromial fracture seems to be a little bit higher. But anyways, historically, somewhere around probably 3, 4, 5% dislocation risk. Couple papers, or I think really just this one paper for this. So this is with the complications of RSA research group, which really has, at least from what I can tell, has probably pumped out some of the best studies out of these ASCS research groups so far. But basically, they were looking at predictors of dislocation in reverse. This is the multivariate analysis. There's a bunch of things. This gets a little busy, but a bunch of things that come up here. Things that you need to know is largely this is patient factor related. Males, revision arthroplasty especially. The risk in revision arthroplasty is, or the odds ratio is 5.6. They did also find that not repairing the subscap or irreparable subscap, it's hard to know, is a risk factor. Having cuff disease, basically having a rotator cuff tear, so cuff tear arthropathy, massive cuff tear without arthritis versus osteoarthritis was significant, and then proximal humerus non-union. So if you look at some of the actual numbers here, in this group, again, this is a group of good high volume surgeons for the most part. So their rates may not completely reflect the rates in the entire country, but for primary reverses, so this is all indications, OA, cuff tear arthropathy, massive cuff tear without arthritis. The dislocation rate was only 1.6, which is pretty darn low. That's definitely on the lower end of things that have been published. But when you lump in with revisions, or if you look at revisions, the dislocation rate is 6.5%. And that's in this study. There are other studies that show revision rates above 10%, or sorry, dislocation rates above 10% in people that undergo revision. So again, something you have to counsel your patients on if you're doing a revision. The risk of dislocation is much higher. And then, not surprisingly, if your cuff is intact, the dislocation rate is about half of the average there, less than 1%. Whereas if you have cuff disease with cuff tear arthropathy versus massive cuff tear without arthritis, your risk of dislocation is higher, 2.3% in cuff tear without arthritis. The other main one that I think can be modifiable a little bit, I guess I didn't really talk too much on this slide, but generally speaking, never mind, we'll get back to that, I forgot. So acromial fractures after reverse, this is pretty devastating complication. If you look kind of across the board, even if people heal these things, they still don't do great. They do better than if they don't heal them, but they don't do great. If you do surgery on them, they don't do great. If you don't do surgery on them, they don't do great. So this is something that for me, I really, really work to avoid. And my algorithm is largely based on trying to minimize this risk. But if you look at some of these papers, again, from the same research group, ASCS complications of reverse shoulder group, Mike, you're probably on one of these, I can't remember, but certain patient risk factors to know. So these are more or less the opposite of what the risk factors are for dislocation, but females, rheumatoid arthritis, osteoporosis, somebody with a chronic dislocation, older patient age, are some of the factors that they found. As far as implant factors, hasn't been published yet, but Mike was kind enough to show me some of their data. It does seem like glenoid lateralization or glenosphere lateralization increases your risk of acromial stress fracture, where glenoid medialization generally is more protective. In this group, overall, they found about a 4% risk. Again, if you look historically, some of these numbers are a lot higher. This is only about 2% in people with arthritis and over 5% in people with cuff disease. So over double the risk if you have cuff disease. That's sort of the uniform factor here, is that if you have rotator cuff disease, so basically all the ones with red arrows on here, your risk of acromial fracture, risk of instability, probably a risk of infection, and your outcomes are all worse. If you do a reverse for arthritis, the risk of these things is lower. It's not zero. And the outcomes seem to be a little bit better. This is largely why so many people are abandoning anatomic arthroplasty, like very good, well-respected surgeons, because it's hard to argue with the longevity of reverses, especially because the expanding indications include people with arthritis that you would normally be doing in anatomic. They seem to be doing very well when you do a reverse of these patients. So this is more or less what I feel like. I don't know if you agree with this, Peter, but personally, I think cuff tear without a massive cuff tear without arthritis seems to be a higher risk of instability. Revisions are higher risk for everything. But anyways, some outcome stuff based on what's out there. So, yeah.
I think this is, I agree with everything that you said here, and I think it's really nice to lay out in this table. The problem I always have with this is that it's interesting prognostically, but this is not a surgeon modifiable factor. Right?
Yeah.
Right. So for four of the categories on this table, you don't have another surgical option. So to me, the more interesting discussion is how do we reduce the incidence of these complications?
That's what I want to get to here.
And then there's also the question of anatomic versus. Yeah, I mean, that's one where I personally think that you're right, that probably the outcome is not hugely different between them. But I think if you examine the literature closely when I'm examining those outcomes, my anatomics do better than mine for Christmas.
Mm-hmm.
And I think that makes sense, like just from it's a more normal shoulder perspective. And that matches with Andy Java's study, you know, that they had better range of motion. That matches with a study that it's the guy's name in Cleveland that nobody likes. Obesity.
No.
Obesity is like what happens by just look at my best possible outcomes for anatomic reverse, and the highest quartile is definitely better for.
Yeah, I completely agree. And I mean, that could be its own hour-long. That was my grand rounds talk, which was an hour. I completely agree. I think the three of us feel that way. But you know, what Andy Jawa would argue is that that's true for 2-year outcomes. Is that true for 7 to 10 plus year outcomes? And that I don't think we know.
What did we do?
Maybe.
I mean, that's mine.
Yeah. Okay, so that's a good lead in. So that's really what I wanted to focus on here is what can we do when I'm putting a reverse in somebody? Do I just put if I'm using DJO, do I just put a 36 neutral, 36 millimeter glenosphere neutral, so that has 6 millimeters of lateralization, and I put an inlay humerus for everybody? Is that what I do? And there's probably people that do that. That's not what I do. And I really do change things based on the patient. And some of this might be a little bit exaggerated, but I think it proves a point. And I do think that it actually probably matters. So glenoid lateralization. So these are all things, I guess I should probably go through this. Jake, I think you saw this, right? Yeah, you found this. So this is probably more for you. I think the rest of us kind of understand this, but there's sort of when you're talking about glenoid versus humeral versus global lateralization, medialization, these are the sort of 4 general categories. This is very difficult because you can take any system and any implant and make the glenoid lateralized. You can make it medialized. You can lateralize you can have an inlay humerus and you can lateralize that. And it gets very gray, but generally, if you look at that Gramont style implant that we talked about earlier, That's the one all the way on the left. So on this implant, the center of rotation on the glenoid is medialized. And by medialized, we're saying center of rotation is probably 0 to 4 millimeters offset from the glenoid bone junction. And then the humerus is also medialized. And this was accomplished by having what we call an inlay humerus. So the humerus, when basically every reverse that we did was an inlay humerus. So we reamed out the humerus and the stem sat inside the humerus. So by effect, that shifts the humerus more medial. And what they're kind of showing here is the humeral offset. That's measured by the point of contact between the polyethylene liner and the center of the shaft. So for a medialized humerus, that humeral offset is somewhere 10 to 14 millimeters probably. So medialized on the left, that's Grammont style. That would be like your delta extend. The next one over is a lateralized glenoid and a medialized humerus. So they're actually showing Frankel's implant here, the Enovis implant. So the center of rotation is lateralized compared to the center of rotation of the Grammont style. And they show 10 millimeters here. Lateralized is probably greater than 4 millimeters in general, if you're calling it more of a lateralized type implant. And then the humerus is still medialized though. So lateral glenoid, medial humerus. The third one from the left, I guess the third and the fourth one really are more of the, I guess, more exact tech type, but the humerus, sorry, the glenoid is medialized. So the center of rotation is medialized. They're showing this at 2 millimeters. But then you're actually lateralizing through the humerus. And the way that you could do this generally is by doing an onlay prosthesis. So the base of the prosthesis is sitting on top of your humeral cut instead of inside your humeral cut. And you can see what essentially that does also by the dimensions of the implant itself is it will offset the humerus more laterally, which is shown here at 21 millimeters. And then you can also lateralize on both by putting a lateralized glenosphere or bone graft or something like that, and then also lateralizing on the humeral side with an onlay type prosthesis. So these are the general concepts. We kind of talked a little bit about this before. And I'm basically going through a couple of things that we modify as we do reverses and why I do what I do at least. So on the left here, just by x-rays, this is a medialized type implant, right? So the center of rotation is more medialized, the humerus is more medialized. On the right, this is showing a lateralized glenosphere and a medialized humerus. You can lateral, so just talking about the glenoid side, you can lateralize by doing a couple of things. One, you can have a glenosphere that by design is more lateralized. That would be like the Enovis system or the DJO system that we were using. You can also lateralize through the base plate, which is what we did here. This is the center, the actual glenosphere is not lateralized at all, but there's 6 millimeters of lateralization through the base plate there. You can also lateralize with bone graft. Pascal Boileau had talked about this bio-RSA, where basically you take bone from the humeral head and you put that between the base plate, between the glenoid and the actual base plate, and that will lateralize. In general, if you're lateralizing on the glenoid side, the advantages to this are you help improve or decrease the risk of scapular notching. And again, depends on how you do it, but in general, you move the humeral bone away from the scapula, so you're decreasing scapular notching. You're probably helping with motion overall, but especially rotational motion, and you're stabilizing it more. Again, just talk about glenoid lateralization. As you put more tension in the system, you're stabilizing more. Probably the biggest risk that we know of here is, number one, it puts a lot more torque on the base plate bone junction. So in theory, you could have failures there. With modern implants, that doesn't seem to be as much of a problem. And most likely, it seems that too much glenoid lateralization probably increases your risk of acromial fracture. Humeral lateralization, so these are two different types of implants. Peter, I still want your x-rays for this, but it's beautiful. It's really well done. So on the left is an inlay humerus, right? So we reamed out the humerus. The actual implant is sitting inside the humerus, which will medialize the humerus more. On the right, it's more of an onlay type. So the cut of basically the tray is sitting on top of the cut. And you can see that the humerus is pushed away from the bone farther. So what is the purpose of lateralizing the humeral side, or the advantages there? So this, in theory, can help improve motion, improve elevation. There is this idea of, well, it's probably not really much of an idea, but it is more easily convertible from anatomic to reverse with this type system. May not be as much of a case anymore. And then humeral lateralization as opposed to humeral medialization, if you're not changing anything on the glenoid, does help improve stability by increasing the deltoid wrap around the greater tuberosity. With some of Heath's data, this probably, as you have a onlay lateralized humeral type system versus an inlay hit system, the forces on the rotator cuff are probably less physiologic. I don't know if you'd agree with that. I think that's more or less what Heath had shown with his, at least with the striker. Glenosphere size. So this is something that, especially from a trainee standpoint, you probably just show up and it's like, okay, well, great, we're doing a 42 on this one, we're doing a 32 on this one. These are pretty big differences in sizes. And on a daily basis, I use very different sizes of glenoid. You can see here on the left is a 40 millimeter glenoid, and on the right is a 33 millimeter glenoid. So what are the advantages and disadvantages here? I don't know if this is as clear in the literature. So some of this might be a little bit more theoretical, but larger size should help with stability, similar to like a hip with jump distance. A larger glenosphere size, as far as planning goes, will improve your motion. I don't know if that's the case clinically. I don't know if haven't seen anything that shows glenosphere size that actually changes range of motion or functional outcomes, but if you guys have seen anything. But larger size in theory, they put more torque on the base plate. And really, when we do this, people talk about trying to match the native glenoid size, or basically match the patient. And, you know, I think if you put a glenosphere that is too big in like a female, you're basically kind of overstuffing things in here, and you're asking the rotator cuff to move around a larger sphere, and it doesn't really fit as well. But anyways. Yeah.
There is some element of contradiction with regards to what you would see about placement purely.
Yeah.
I don't know.
I agree. I've like looked for clinical data on this, and I really don't see it. So a lot of this is more gestalt, but
I thought there was a randomized clinical trial of 36 versus 40 that showed no difference. I think it's an Asian study.
I think you're right that there is a study. It's a sphere size, and I want to say that there's a clinical study that looks at sphere sizes using the one style method, which shows better stability. But I don't know. I can't remember what the study shows with regards to range of motion.
couple other points here. So base plate position, this is really just more in general what we try to achieve. You want the base plate, or at least the center of the base plate, to be in the inferior half of the glenoid. You want the inclination or the tilt to be neutral or inferior in relation to the base of the supraspinatus fossa. The version of the implant, you want it to be neutral or retroverted. You don't want it to be anteverted. You don't want the base plate to be too anterior in the vault. And then inferior overhang. I will tell you, if you're using a 135-degree neck shaft angle, the inferior overhang and having the implant be more inferior in the glenoid probably are less important. But anyways. So humeral neck shaft angle, this is a little bit more generalized here, but so there's, I mean, you could probably build, I don't know, probably 10 different inclination angles with different types of implants these days, but generally it's 135, 145, 155 is what you have available. With a 135, which is largely what I use, again, scapular notching is not as much of an issue. This probably improves your internal external rotation, probably decreases your forward elevation ability. And it just has to do with the amount of distalization that the humeral component, or basically that the humerus has. With a 155, or deltoid tension probably helps with forward elevation, probably limits your internal external rotation a little bit more. Yeah. These X-rays kind of show it best. So if you look at the DJO one right here, base plate's up very high, but if you have a 135-degree neck shaft angle, you're generally not hitting the inferior. That's probably higher than I would normally put it, but you don't have to worry about it. But if you are using a 145 or 155-degree angle, you really have to make sure you have some inferior overhang, I think, on your glenosphere. Whereas you probably, I mean, if you look at what Frankel does, he does it. He puts it like right in the center of the glenoid, and sometimes there's still bone down there. But it just has to do with where the humerus is in relation to the scapula. I think this a little bit generalized, and I'm going to go through my quick algorithms in the next two slides. But I think this is like largely what I shoot for, and I think if you look kind of across what most people are doing and what literature more or less supports, we're generally shooting for glenoid lateralization, at least a little bit of glenoid lateralization, somewhere in that 3 to 6 millimeters. You know, too much lateralization probably increases your risk of acromial fracture. Too little lateralization probably decreases your range of motion. Humeral inlay versus onlay, I mean, you can look at some of Heath's biomechanical data, but largely there's really nothing from a clinical standpoint to push you one way or another. Inclination, for the most part, unless there's patient-specific factors, most people are using somewhere in the 135 to 145 range. Glenosphere size, as we talked about earlier, I don't really know from a clinical standpoint if there's much to go off of here. Larger size improves stability, and glenosphere position. Really, what I try to do, and I think are probably the two most important things, is don't superiorly tilt it in relation to the beta angle, and don't antivert it. I think those can lead to some issues. Some of the other stuff may not be as important depending on the implant. So I've got two slides here. This is my algorithm of nonsense. This is what I do. So this is not what you guys do necessarily, but my thought process here in women, I am largely trying to improve their range of motion. But a lot of my decision factors are trying to avoid an acromial fracture. So what I do is if the acromial fracture risk is high, I lateralize less on the glenosphere. Usually I'm still lateralizing 3 millimeters unless they're really high risk. Then sometimes I will do an actual more Grammont type style implant and not lateralize it at all. But largely I'm lateralizing 3 millimeters, 4 millimeters, something like that. If their acromial fracture risk is low, so like an OA patient, something like that, I'll actually lateralize a little bit more, especially if I'm using a smaller glenosphere size, usually somewhere in the 3 to 6 millimeter range. In a female, I'm really not ever lateralizing more than 6 millimeters on the glenoid side. Height, this is really kind of rough, but shorter females, I'm using a 32 or 33, even with the striker system. Taller females, I'm using a 36. If their cuff is intact, I'll use a non-retentive liner typically. And also, in a female, I'll really try to do an anatomic if I can. And then if their cuff is not intact, I'm generally putting them in a little bit tighter just to avoid late instability problems. But again, this is sort of a balance between what their acromial fracture risk is. And then sometimes if their cuff is intact for a female, I'm actually putting them in less humeral retroversion. Not that this may or may not matter, but I think it might help them reach behind their back when their cuff is not intact. As far as the neck shaft angle, the vast majority of what I use is 135s. Unless they're upper extremity weight bearing, then I will use a 145. Very different from what you guys do, I'm sure. I don't know if you have any comments.
I actually should be. There is, so there was, I actually asked him, your list. I was like, what, you know, this is probably 10 years ago, past, patients with osteoarthritis, et cetera. And for a long time, I would cut the entire supraspinatus and infraspinatus. Cut that supraspinatus back to the supraspinatus. Probably then catches up with the infraspinatus because it's out. And I did that forever, and I did it for because it's smoother. It's just like easier to take more president to clean up the supraspinatus out of dislocation, etc. It's just easier. We were talking about a case article that we published on the way. First, which was probably the first that was published on the way. And I was like, we were talking about this, and he was like, oh, I never converted it. It's like, you didn't describe that on the paper, it's not like in there, or whatever. It's like, yeah, I've never, with an osteoarthritis, I've never converted it. It's like, oh, okay. So then I started not having a rotator built in every single reverse that I had to put back rotator. And then, I don't know, a year or two ago, I was talking about the same exact topic, and like with Jim Orange and Jay and Joaquin, and like, I don't know, there's probably half a dozen people that were there. And they were saying, oh, I took the supraspinatus in every single case of it. And it's like, okay, why? And they're like, well, it's clear that it's antagonistic with the parts that are like that. Your difference probably not require with regards to function of the supraspinatus actually. And you can show that seems like that's true by simulator. I think maybe a lot of the HSS guys did it with Contaxis as well, and showed the supervised ability against the and it becomes basically as it was higher degrees of that function of rotator above, it's basically fighting super, or at elections. But anyways, then it's like, okay, well, maybe I should be cutting the super spikes. So, but I agree that it probably helps with stability, in what I mean.
Mhm.
So, kind of conflicting. I think you're right, probably the patients that don't have any factors are of having a higher risk for instability. Although I'm not sure AD standards are really prescribed. You know,
Yeah.
say that patients have instability, patients that have arthritis. There's a lot of differences between those two disease processes.
Sure.
So you're making the presumption that making it matters between them, and I'm not sure you can. But I think we can just kind of understand about it. Neither attended those times, and it's basically.
Yeah.
I like the idea of extremely great training. I'm never using one on myself personally, but I think it makes sense for to options efficient.
Yeah. This is same thing for men. Basically, my bigger concern for males is instability. So my algorithm is a little bit more directed towards that. You can see the larger glenosphere sizes here. Generally, a little bit more lateralization for all men for me. And then the cuff intact part for me, I'm really pushing if they're a massive cuff tear without arthritis, cuff tear arthropathy, I'm putting them in pretty darn tight, usually with a larger glenosphere. But that's it. Yeah, I know. I've had few, not of my own, but of that have come in from Idaho, like 3. Idaho.
Maybe, I mean, I don't know, I just think of my own patients that are treated.
Yeah.
The ones where I'm having problems with them. But they are doing good. That's usually.